Good morning, good afternoon, good evening to all participants who have gathered to listen to the nursing session of IAPCON 2022. The session is Nurses in Action, Best Practices in Empathy and Empowerment. So we welcome all of you once again, and let me introduce the eminent speakers, the chairpersons and moderators. I am Manu Savyatelli, currently working as nurse consultant in the Department of Palliative Medicine, Mahatma Gandhi Medical College and Research Institute, Pondicherry. It's a big honor for me to introduce everybody to this wonderful nursing session. We have tried to fill with maximum practical solutions to all the problems which one face in a home care setting, multiple setting, whichever possible. And we have also tried to answer all the queries and questions in the best possible way that we can. Now it's a proud privilege for me to introduce Terry, who is moderating this session. Terry has completed BS in nursing, and he has also masters in public health administration with 5 years of palliative care services. Currently, he is working as a palliative care coordinator at Christian Fellowship Hospital, Ottanchitram. His major achievement include he is selected as one of the pioneering nurses in palliative care by St. Christopher's Hospice, London, United Kingdom, and contributed and compiled a very beautiful book, very great resource for the nurses in low middle income countries, that is home-based palliative care, a manual for nurses. And he has also co-authored two publications. Another is our Sankita Madam. She is currently working as nursing tutor in Bangalore Hospice Trust, Karnataka, with 19 years of vast experience. Her topic of interest is palliative care research, and her major achievement include Best Nurse Award, CREAM Award, and academic topper. She's also faculty for IAPC, Impact HN, NFR, and NHSRC. And she has been a speaker for state, national, and international workshop. She has many peer-reviewed paper publications in different journals and has written chapters for textbooks for palliative care and contributed to various curriculum planning. It's my honor to introduce Dr. Leta. Currently she's a tutor in College of Nursing, AIMS, Jodhpur, with 23 years of experience in nursing. And her area of interest is palliative care, pediatric nursing, and nursing research. She has attended and organized several local, state, national, international conferences, workshops, and seminars, presented many papers and posters in the conference, conducted one project with International Fund and part of National Fund project, trained and contributed to medical and nursing curriculum development for palliative care, received 8 awards and merits from CMC Vellore for education and administration, research and dissertation, general proficiency, and cultural activities, including Akama J. Chacko Prize for Best Clinical Student. She has 18 publications in national and international journal, and authored 2 chapters in 2 books. It's my honor to present Mrs. Neelima ma'am. She is a senior nursing officer in AIMS, New Delhi, with 24 years of vast nursing experience. Her area of interest is palliative care, medical oncology, and transplant. Her major achievement include Best Nurse Peer Review Group Award in 2014 from Tata, poster presentation at Singapore Conference in 2018, first prize for Hindi essay writing twice, CT 123 faculty, LNAC India faculty, got opportunity to share knowledge on palliative care for more than 600 nurses all over India for LNAC and CTC, secretary for ONAI Delhi chapter since 2014, conducted breast awareness program for common public, published 2 chapters for Pain and Palliative Care Guide 2021, e-publication for IAPC, APHN reports of LNEC program. I don't have to introduce Stella ma'am in IAPCON. And if I go on reading her CVs, and her contribution to palliative care nursing is immense. For someone who, I don't think anybody is there attending this conference without knowing her. It's my honor to introduce her. She's a retired army nurse, affiliated with almost all the leading organization in our country and abroad, with vast 35 years of experience. Her major achievements are many, but few of them I am listed out here. Best Nurse Award, Award of Excellence, and she has authored books, recognition as a national leader 2020 in the International Year of Nurses and Midwives. She has participated in national consultation for creation of palliative care curriculum for undergraduate medical and nursing students for training physicians in recognized medical institutions. Author of the module on nursing issues for the 1-year National Fellowship in Palliative Medicine and Nursing. One of the member of core committee in preparing curriculum for BCCPN and BCCPAN. Resource person for the facilitator guide and training manual for Ministry of Health and Family Welfare, Government of India. Ms. Shaini, I am going to introduce speakers along with the topic. Ms. Shaini will be taking lymphedema. Currently, her designation is staff nurse with over 20 years of experience. She is a staff nurse in Institute of Palliative Medicine, Calicut, Kerala. And Sangeeta ma'am, I have already introduced her. Ajisha from Amruta Institute of Medical Science will be dealing with the shifting of patient, transferring the patient to wheelchair. She has more than 3 years of experience, and her major achievement include pain evaluation and management. And it's again an honor for me to introduce Shakila ma'am. She is charge nurse in CMC Vellore for more than 18 years of experience. And her major achievement include receiving the Nurse Leadership Bursary Program from St. Christopher's Hospice, London. And she is a faculty for most of the training programs in India, including LNET. And in 2013, National Consultation for Creation of Palliative Care Curriculum for UG medical students. And she has many publications in her credit. Mamda, next, she will be presenting care of bedridden patient. And Mamda Parihar, Mamda will be presenting care of tracheostomy patient. She's currently a lecturer in SN Medical Government Nursing College, Jodhpur. Her major achievement is she's currently PhD scholar in Geetanjali University, Udaipur, and she has many publications to her credit. And next speaker is Sumitra. She will be presenting subcutaneous infusion. She's a senior staff nurse and ward in charge at Bhagavan Mahavir Cancer Hospital and Research Center, Jaipur, with vast experience of 17 years. And her area of interest is palliative care. And next is, one second. Our next speaker is Durga Bhavani. She's a staff nurse in Homi Baba Cancer Hospital and Research Center, Visakhapatnam, with over 10 years of experience. And her major area of interest is oncology, psychology, and intensive and emergency care. And final speaker is Maheli Chakravarti, CEO of Ruma Abhidona Hospice with over 10 years of experience. Her area of interest include grassroots level palliative care, bereavement care, and end-of-life care. Her major achievement includes over 3,000 home-based palliative care from last 10 years. Over 15,000 patients attended in her hospice and palliative care services, OPD. Approximate 4,000 wound care for advanced palliative care, which is quite a large number. Bereavement care is also achieved in her hospice. And she has been selected by ESI Manikdala, Kolkata as a trainer of certificate course in palliative care. And over to Stella ma'am now. I shall stop my screen sharing. Over to Stella ma'am to start our session.
Thank you so much, Anu, for introducing all the speakers, moderators, and the chairperson. So now we are going to have lymphedema, and the speaker is Shaini.
Hi everyone, myself Shaini from Calicut, working as a staff nurse under the Institute of Palliative Medicine since 20 years. Today I am going to present management of lymphedema in palliative care sector. First of all, I thank the organizers for giving me an opportunity to present this topic in this prestigious conference. Lymphedema management is a large topic. Given the time frame, I am going to present only the basics of lymphedema management.
As you know, lymphedema is defined as the accumulation of lymphatic fluid within the interstitial space due to an imbalance between the production and transportation of interstitial fluid, resulting in edema. It usually presents as swelling of one or more extremities along with the swelling of the corresponding trunk.
Based on etiology, lymphedema is classified into primary and secondary.
Primary is mainly due to congenital defects.
Causes of secondary lymphedema are surgery, trauma, malignancy, infection, venous disease and immobility. Identification of lymphedema. It is important to identify lymphedema from other edemas, as the management is different in different cases. A proper history is very important. In palliative care, history of malignancy, surgery, chemotherapy and radiotherapy should be taken in detail. Next is physical examination. The characteristics of lymphedema are swelling of the affected limb, heaviness, tightness and fullness, hyperkeratosis, positive stemmer sign, inability to pinch and lift skin fold at the base of the second toe or middle finger. Problems due to lymphedema are pain and numbness, skin folding, fungal infection, lymphoria, cellulitis, heaviness and psychological issues. As you know, once the lymphatic drainage is blocked, it is very difficult to reverse the mechanism. To reduce complications and improve quality of life, proper and regular care is very important. The aim of lymphedema management is reduce edema, prevent further developments, reduce complications, improve functionality, reduce psychological problems. Treating a patient with lymphedema usually requires multidisciplinary team. The management is broadly classified into skincare, compression garments, massage and exercise. These are called the four cornerstone management of lymphedema. In addition to this, caring for patients' psychological needs is crucial in ensuring adherence to the treatment plan and in protecting the patient's mental health. Keep the skin hydrated by applying moisturizers daily. Avoid soaps that cause dryness. Protect from insects bites. Avoid tight-fitting clothes and BP recording in the affected arm. Avoid vigorous rubbing while drying. Regularly monitor the web spaces and clean the area. Protect from direct heat and sunlight. Avoid lifting heavy items.
Materials used for compression are cotton roll, gamgee pad, crepe bandage. For mild lymphedema, hosiery can also be used. Both the patient and the carer should not use any ornaments of sharp objects while doing the procedure. Proper measurement is very important. Limb should be placed on a flat surface. Use non-elastic tape. Both the affected and unaffected limb should be measured for comparison. For upper limb, 2 cm from styloid process of ulna and thereafter 4 cm should be marked up to shoulder. Circumference of each marking should be recorded. Usually multi-layer bandaging is done. For first layer, cotton roll or cotton cloth can be used to get the cylindrical shape, prevent folding and to get equal pressure. Pressure bandaging should start from wrist onwards. The order and method is clearly demonstrated in the video. The bandage width for fingers is approximately 3 cm and for other parts approximately 6 cm. It can go up to 8 to 10 cm depending on the size of lymphedema. Pressure bandaging should be avoided in case of severe lymphorrhea. Bandaging should be repeated every 24 hours. Sharp clips should not be used to fix cotton rods or bandage. Instead, plaster should be used. Hosiery should not be used during night time to prevent skin folding. Next step is massaging, but before massaging, breathing exercise should be done. 10 deep breath in and breath out are ideal. Aim of massaging is to stimulate normal lymphatic pathway. Two types of lymphatic massage: manual lymphatic drainage and simple lymphatic drainage. In this session, I will be dealing with the simple lymphatic drainage only. Start from back of ear, move towards neck. Each massaging strokes should be repeated 10 times. After that, in the supraclavicular region. In this area, massaging should be more deeper. Massaging should be done on the unaffected side. Strokes should be towards the unaffected side. Upper chest massage is up to nipple level. Massaging should be done on the unaffected axillary region also. Breathing exercise should be repeated after massage. Aim of the exercise is to facilitate lymphatic drainage, increase muscular strength and improve cardiovascular function. Method is 20 times stretching of fingers and releasing. Next is tight fisting 20 times. Next is extension and flexion of palm at wrist joint 20 times each. Next is rotation of wrist joint clockwise and anti-clockwise 20 times each. And flexion at the elbow joint after fisting and rotating as shown in the video. Massaging and exercising should be ideally repeated 4 times daily, at least minimum 2 times. Due to the time constraint, I couldn't include lymphedema care of lower limb in this session, but I would like to mention few points to consider. Breathing exercise, massaging of the neck and clavicle similar to upper limb. Massaging of the axilla on both sides should be done. Chest massage towards the neck. These are the contraindications for lymphedema care: cellulitis, severe cardiovascular disease, severe respiratory disease, severe peripheral neuropathy. Maintenance are proper follow-up, teaching the caretaker, and lifelong care. I am summarizing this session. Prevention is better than cure. Identify early and start early. Proper history and assessment. Address psychological problems. Consider 4 cornerstones. Thank you. Thank you very much.
Thank you so much, Shaini. To summarize, lymphedema can be managed if timely assessment is done, diagnosis, and of course, the interventions. So we need to empower and educate all the patients and the family right from the time they have undergone a surgery so that timely intervention can prevent lymphedema. So over to Anu.
Next, I call Neelima ma'am to introduce the topic.
Good afternoon, all. I would request Sangeeta ma'am to kindly present her topic.
Wound management in palliative patients is often a very challenging area of care. There are many unique issues that can combine to produce complicated wound management scenarios, including the type of wounds and wound symptoms most commonly affecting palliative care patients, as well as the presence of concurrent disease and associated treatment. Problems exist with the availability of suitable dressings and balancing life expectancy with the goals of wound care. Malignant or fungating wounds occur when cancerous cells invade the epithelium, infiltrate the supporting blood and lymph vessels, and penetrate the epidermis. This results in a loss of vascularity and therefore nourishment to the skin, leading to tissue death and necrosis. The lesion might be the result of a primary cancer or metastasis to the skin. Prevalent rate 5% in advanced cancer patients, 10% in metastatic condition, 6 to 12 months of life expectancy, which interferes with the quality of life dreadfully. Mrs. Sidamma, 45 years, widow, working in a silk factory, was diagnosed with invasive carcinoma left breast stage 4. She has undergone 9 cycles of palliative chemotherapy, but now has advanced metastatic disease. She has 3 sons, all are unmarried. Eldest son is suffering from a chronic illness. Second is the breadwinner of the family. Youngest son is studying and the primary caregiver for his mom. She was admitted to the hospice with complaints of dyspnea, fever and chills, hoarseness, dysphagia, lymphedema in the left arm, and disturbed sleep. She has an ulcerated wound over the left breast extending into the supraclavicular region. She complains of mixed nociceptive and neuropathic pain radiating towards the face, neck, and shoulder. Her wound is ulcerated, granulated with severe pain, malada, exudates, and bleeding. She is bedbound most of the time. Here, the question is not about the cure, but how to live. This wound assessment helps and defines the status of the wound. Time tool assessment helps to identify the difficulty of wound healing. Goals of care: providing comfort by focusing on physical, psychological.
Hello.
Gaurav?
Malada, exudates, and bleeding. She is bedbound most of the time. Here, the question is not about the cure, but how to live. This wound assessment helps and defines the status of the wound. Time tool assessment helps to identify the difficulty of wound healing. Goals of care: providing comfort by focusing on physical, psychological, social, and spiritual management, eliciting patient concerns, facilitating informed decision making, focusing on quality of life even in final stages. The issues are physical, psychological, social, and spiritual problems. Physical problems are pain, malada, bleeding, infection, exudates, infestation with maggots. Psychological aspects are body image alteration, denial, sexuality, fear of death, depression and anxiety, embarrassment, shame, revulsion, isolation. Social aspects are family isolation, social stigma or fear of contagion, effects on family, effects on sexual relationship and marital disharmony. Spiritual aspects are interference with religious rites, punishment from God, fear of impending death, existential dilemmas. Before starting the procedure, introduce yourself to the patient and explain what you are doing and why. Provide privacy. Position the patient comfortably and make sure the surrounding area is clean and tidy before you start. Check the patient's record to update yourself on any changes in the patient's condition and to make sure the dressing is due to be changed. Arrange all the articles beside the patient. The next step is removal of old dressings. Wash hands thoroughly. Put on non-sterile gloves and remove the adhesive tape, bandage and superficial compresses. Proceed gently with the last compresses. If they stick to the wound, loosen them with 0.9% sodium chloride or sterile water before removal to prevent the pain and bleeding. Observe the soiled compresses. If there is significant discharge or a foul odor, a wound infection is likely. Discard the dressing and the non-sterile gloves in the waste container. Pain. First, do the assessment. For deep pain, give systemic analgesic or opioids 30 minutes before the dressing. For superficial pain, local application of lignocaine, sensocaine, opioids, and sublingual ketamine. Malada, local cleansing, which involves showering, gentle saline irrigation via pressure from a syringe with 19 gauge needle. Removal of necrotic tissue by gentle irrigation, autolytic debridement or local debridement of dead tissue. Managing exudates using hydrocolloid dressing with frequent change of dressing. Use of systemic antibiotic based on culture or use of tropical antibiotics, example metronidazole. Use of activated charcoal dressings or barrier dressings. Preparation of Vaseline gauze. Tablet metronidazole 200 mg. 6 packets, each packet containing 200 tablets, crushed and powdered to be mixed with 1 kg of Vaseline. Apply the mixture on the gauze pieces and arrange it in a steel tray. Pack the tray and send it for autoclave. Preparation of charcoal powder. Collect dry coconut shells or wood pieces. Burn them and get the charcoal. Dry well and grind them. Sift and get fine charcoal powder. Fill it in a steel airtight container and send for autoclave. The activated charcoal powder is now ready. Bleeding. Prevention. If dressing adhere, carefully soak off with saline gauze. In case of bleeding, apply local pressure for 10 to 15 minutes. If bleeding still persists, use cyclophosphamide powder. Adrenaline ratio 1:1000 dilution. Motrophase, systemic ethamsulate. Start oral antifibrinolytics like injection tranexamic acid. On rare occasions, the tumor or wound will erode a major vessel, resulting in a fatal bleed. These can be distressing situations, and being prepared ahead of time can be helpful. For example, using dark colored sheets, having dark towels available, preparing family and friends ahead of possibility. Infection, chronic and localized. Check for inflammation. Daily dressing with metronidazole, no betadine and hydrogen peroxide. Maggots. Always be proactive to prevent the infestation of maggots. In case of infestation, apply turpentine. Sprinkle over the area, leave it for 3 to 5 minutes. When used on patients with buccal mucosa, kindly cover their eyes and nose as it is highly irritant. Manually remove the maggots with artery forceps. Discard it in the kidney tray with warm water. And mercurochrome 2 to 4% can also be used. The palliative wound care management does not end with the hospice. It extends to the family caregivers. Therefore, it is important to educate and empower the caregivers by assessing their knowledge, attitude, and practice. Practical demonstration of wound dressing, regular follow-up with caregivers, realistic goals of care, which involves improving quality of care and palliation of symptoms. Teach the preparation of normal saline, which is 1 liter of water with 2 tablespoons of salt, boiled. Preparation and sterilization of dressing materials. The use of clean and old cotton clothes can be used if steamed in pressure cooker for 30 minutes. Provide psychological support to the caregivers. To sum up, make sure the wound is clean, moist, covered with a waterproof surrounding tissue and protected.
That was really a wonderful video presentation by Sangeeta ma'am and her team. And really, wound management is very difficult for the family at home. And when we talk about palliative care, I think it is very necessary to teach the family members, and this Karuna Shrai is doing a wonderful job for that. And I congratulate Sangeeta ma'am. I request participants kindly put your questions in the chat box so we can answer at the end of the session. Thank you.
Requesting Leather ma'am to introduce the topic.
Good afternoon. I would like to call upon Shakila ma'am with her video on care of bedridden.
Greetings from Christian Medical College, Vellore. I am Sister Shakila.
I am Sister Celine. I am Sister Anita.
This is an educational video on nursing care of a bedridden patient. Who is a bedridden patient? Bedridden patient is someone who is mostly confined to the bed, and this could be due to various reasons like paraplegia, fracture, generalized debility, and at end of life. We come across such patients very frequently in palliative care. In such patients, nursing needs are many, which includes personal hygiene, bladder and bowel care, prevention and care of pressure injury, education on exercise and nutrition, assessment and support of psychological and spiritual issues. Under personal hygiene, we should consider general hygiene, oral care and perineal hygiene. In general hygiene, to enhance the dignity of a patient in bed, maintaining good general hygiene is important. Hair wash with shampoo weekly once or twice. Eyes should be cleaned with wet cotton ball from inner to outer canthus. Patient should be given bath every day with soap and water, including cleaning the private parts. Regular trimming of nails using nail cutter should be done. Oral care should be provided on a daily basis. Assess for xerostomia, halitosis, mucositis and oral candidiasis on daily basis and refer for appropriate treatment if present. Good oral hygiene, the following solutions can be used: normal saline, diluted chlorhexidine, thymoglycerin and homemade solutions for mouthwash using salt, lemon and soda, that is cooking soda. How to make a homemade solution for mouthwash? Take a half liter of water, add 1 teaspoon of salt, boil it and cool it, then add 2 pinches of soda bicarb and a half lemon, squeeze into that. Perineal hygiene. Perineal hygiene should be maintained by cleaning the private parts with soap and water and patting it dry. In the hospital, benzene conium chloride is used. Carefully looking for any excoriation present. If present, zinc oxide can be used for topical application. Perineal hygiene has to be performed thrice a day.
For bedridden patient, bladder care is very important. So encourage adequate hydration. If continuous bladder drainage is present, pull the catheter gently and clean with a circular stroke around the urethral meatus using betadine from inner to outer aspect for 4 inches. This is to be performed twice a day. Urinary catheter should be changed regularly. If it is Foley's catheter, once in 3 weeks. If silicone catheter, once in 3 months. If patient is on condom catheter, catheter has to be changed daily. Urobag should be emptied when it is filled 3/4. Coming to bowel care, for bedridden patient, bowel care is very important. All measures to encourage regular bowel movement should be taught. In bedridden patient, regular movement might not be just achieved by high fiber diet and hydration. Most patients will need regular laxatives. If patient is constipated for more than 2 days, a rectal examination should be done. If stools are very hard, then a manual rectal evacuation using good lubrication should be done. This should be followed by insertion of dulcolus suppositories. For any rectal examinations or measures, position the patient in left lateral with the right knee flexed and left leg straight with the patient's back facing towards nurse. Wear the gloves and lubricate the index finger. Take the bisocodal suppository, insert gently in the rectum along the rectal wall higher up. It is important to remember the bisocodal suppositories are stored in the refrigerator. In paraplegic patient with absent anal tone, insertion of bisocodal suppositories followed by digital rectal evacuation has to be carried out in initial days to train the bowel. Once bowel is trained, only digital rectal evacuation is enough.
We will now look at prevention and care of pressure injury. It is important to know that different pressure points earlobes, scapula, elbow, sacrum, trochanter, knee, ankle and heel. Gently massage on the pressure point areas with moisturizer thrice daily and look for signs of pressure injury. Stages of pressure injury. Stage 1, the skin is intact with change in color, either black or red. There may be burning or itching and warm to touch. This is a stage 1. Stage 2 is loss of dermis with redness, with or without oozing of clear fluids, and it is painful. Stage 3 is subcutaneous involvement of the tissue, bones and muscles or tendons are not exposed in this. Slough may be present with malodor. Stage 4, full thickness tissue loss with exposed bone, tendon or muscle. Slough or eschar may be present. Undermining or channeling may be present in this. There are other preventive measures also includes make a bed every day with wrinkle free, tucked in, preferably cotton sheet. While shifting the patient, do not drag the patient on the sheet. Change position every 2 hours. Once the sheet is wet, change it immediately. We will have a short demonstration on positioning the patient using pillows. Massage the pressure point areas adequately using moisturizer at least twice a day. Inspect the pressure point areas every day, that is mandatory. Make sure patient is lying on a wrinkle free bed, and air bed is important to release the pressure. Now I am going to demonstrate on positioning the patient using pillows. When a patient lying on a supine position, keep one pillow just below the knee. Make sure patient is relaxed. One pillows in the head, one pillows in the arm. Placed correctly. This is the position for the supine. Coming to the lateral position, turn the patient in a side lying position. When a patient paraplegic, use a sheet to log roll. One pillow on the back. One pillow in between the knees. Okay. One pillow, and for the heel. This is a 5 pillow technique.
Now we'll go on to demonstrate exercise to prevent DVT and edema. So this range of movement exercise to all joints, all 4 joints is very important. Now I will demonstrate to the lower limb range of movement exercise. Mainly this active and passive exercise to be performed daily twice a day. So first each joint we have to give some movement. First the toes, just we have to, each toes we have to move up and down like this daily, morning, evening 10 times. Then ankle movement up and down, then rotation clockwise, anti-clockwise, then knee joint, just flexion. Then you have to stretch the leg, the side, like this, then full leg we have to move up and down like this. This is the simple range of movement exercise daily we have to do, daily morning and evening. For bedridden patient, exercise plus the TED stockings also is very important to prevent deep vein thrombosis. Diaphragmatic breathing exercise also very important for the bedridden patients for the lung expansion and the fluid circulation. Now I will just demonstrate with the patient. Just take deep breath from the nose and slowly you exhale through the mouth. Do no? How much she can able to do? They have to exhale the air. This exercise every 2 hours they can do it for 10 times. It has to be performed in empty stomach. That is good for the circulation.
While feeding a patient, make sure patient is in upright position to avoid aspiration. Small frequent feed 6 to 7 meal per day is required for this patient. Give easily digestible food. When patient is coughing while feeding, stop the feeding. Make sure patient doesn't aspirate. Do not force the patient to take food for more than what they can take. When a patient's on NG feed, make sure this sitting position is mandatory. And also after feeding, make sure 30 minutes patient remains in the Fowler's position. Assessment and support for psychosocial distress and spiritual need in all palliative care patients is very important, especially those who are bedridden. Involvement of the psychologist, counselor or a chaplain in care of such patient is useful. Take every opportunity as you provide care to communicate and listen to patient and the carer. Take effort to maintain privacy and dignity throughout the care. Involve and teach the caregiver while caring for the bedridden patient. This will empower them to continue to provide care for the patient at home. Be mindful of the need of the caregiver. Affirm and appreciate the care they provide. Assure them of your availability and support.
So this video has been prepared very well with all the nursing care aspects and a few points to add on. Like when we are giving care to a patient, we need to teach to the caregivers because we are not going to be there with them always. And we need to take care of the caregivers' need also. And while providing care, we need to communicate with the patient and observe their facial reactions. And while feeding, as Shakila ma'am said, we need to increase fluid and fiber. And what the patient likes, those food we try to provide. And a few points like when we are giving like a halitosis, like we can prepare like charcoal mixing with salt and soda that can also be used to prevent halitosis. And like bed sore prevention, like we should not massage on bony area and we should not massage on pressure sores. And no, we should not use hydrogen peroxide and betadine solutions. And when the patient is on catheter, we need to take care of the catheter to prevent the catheter associated sore. And we need to keep the skin always dry and any leakage, any wet area that to be taken care. And when we are giving care to nails to a patient, at the same time the caregivers also should take care of their nails. Their nails should be very short. And like when assessing the patient, like we need to follow the mnemonics like MBBS, that is M for mouth, the complete assessment of the mouth, like if any sore or candidiasis, that can be taken care. And B for bowel, as they talked about bowel very nicely, and bladder also, any bladder distension that can lead into delirium, so we need to take care of that. And yes, for sleep and any so like the patients, some of our patients may think that I may not wake up, so we need to see that whether they are sleeping properly. And when patients are having such type of feeling, we should not leave the patients alone, and we should reassure them, and we should allow the relatives to be with the patient. And before going to sleep, we should allow them to share their feelings. And that we need to, these are the, and one more thing, like we need to also concentrate on patients, like some patients, some of our paraplegia patients may be there on the wheelchair, and wheelchair bound bed sore also can happen. So adequate padding of the wheelchair and catheters and dress, all those things we need to teach to the relatives. And when we are coming, we are not only taking care of the adult patients, we are also taking care of the children, pediatric patients. We need to consider like how, like we also have to take care of the siblings with them. And so the entire family care, when we are considering this bedridden patients, we need to take all those four corners. Okay, that's what I wanted to add. Next, I would like to call upon Mamta ma'am to present a video on tracheostomy care. Over to Mamta ma'am.
Good morning to all. Today we are going to perform a procedure which is tracheostomy care. And before starting the procedure, we must be careful about the articles we need. So, before the procedure, we will prepare all the articles. We should have HME, a new HME filter. These are the buds to clean, a fresh track tie, a brush to clean the inner cannula, then normal saline to clean the tracheostomy inner cannula, a disposable kit to check the inflation of the tracheostomy tube. Then we would have a sterile tracheostomy tray. We will have a sterile drape, gloves, a scissors, an artery forceps to clean the tracheostomy tube, a kidney tray, fenestrated gauze piece, some fresh gauze piece to clean the secretions and to clean the site of the tracheostomy. Now, before starting the procedure, after checking all the articles, we will check the doctor's order about the tracheostomy care and suction. First, we will see how the patient's situation and about the pre-medication, and then we will start the procedure. Hello Mr. Rakesh, कैसे हैं आप? कैसे लग रहा है आज आपको? कंफर्टेबल है आप? देखिए, हम आपके ट्रेकियोस्टोमी केयर करने जा रहे हैं, तो इसके लिए आपको हमारे साथ थोड़ा सा कोऑपरेट करना है, ठीक है? So before the procedure, we will introduce the patient, we will talk to the patient, which is very important to give him some comfort. After checking the patient, if he is in a comfortable position, then we will do our assessment. Okay, Mr. Rakesh, breathe. Breathe. Yes, breathe. Yes, breathe. Okay. So, before the tracheostomy care, we will check the saturation also. saturation is okay. Now we will see if there is any prescription of the doctor for pre-medication. Then we will administer that drug before the care. And if the saturation is low, we'll provide or will hyperoxygenate the patient first, and then we will start the procedure. So before starting the procedure, we will check the pressure of the cuff by pressing it. We have to make sure that it should be properly inflated. Otherwise, while doing the procedure, the tracheostomy tube can be dislodged. So that is why we are making sure that it is properly inflated by pressing it. So now, right now we can see it's properly inflated. Now there is another point to remember, that in most of the palliative care patients, the tracheostomy tube is cuffless, because cuffed tube can cause so many complications. So it is more preferable in long-term patient to use a cuffless tracheostomy tube. Now we will prepare our field. First, I will wear the gloves. Now we have a drape. With this drape, carefully we will cover the patient. We should be careful that we should not touch the site of trachea or the inner cannula. Now we are ready to start the procedure. Put the normal saline to clean the inner cannula of the tube. We will have 2 bowls of normal saline so that we can properly clean the inner cannula. Remember one thing, that to clean the inner cannula, it's not always necessary to use sterile saline. We can use homemade saline or hydrogen peroxide, running tap water, or boiled and cooled water. Okay, these are other options also we can use at a home setup to clean the inner cannula. Now first of all, we will remove the inner cannula very gently. Make sure that we should not touch the inner surface of this cannula because it is clean. It's directly in the contact of the lungs. Now with the help of the brush, we will clean it. If there is any secretions or mucus plugs will be present, they will be cleaned. And then we'll shift it into the another bowl. And while cleaning the tracheostomy site and while changing the tractile, by that time this inner cannula should remain in the normal saline only. Now before cleaning, we will loosen up the tractile. We have to be very careful during the whole procedure that the tube should be at its proper place, because now there are chances for the dislodgement as we have opened the tractile. Now we will gently remove the underneath gauze piece. And now we will observe the site of the tracheostomy for any discharge, purulent discharge, skin excoriation, or any redness or bleeding. We will note all these things and we will document if needed. As we can see, the area is nice and clean. We will clean it with the bud. For the other side, we will take the another bud. We have to be very, very gentle and careful for the tube. Now, after cleaning the sides of the tracheostomy site, we'll replace the fenestrated gauze piece. We can use it with the help of artery forceps also. We have to be very gentle while doing it. Now we have replaced the gauze, and now we will replace the inner cannula, and it is a downward motion and the inner cannula is replaced. And after replacing the inner cannula, we'll take the HMA filter and we'll fit this HMA filter, and now we will oxygenate the patient. After the oxygenation, we will check the saturation once again, and the saturation is okay. Remember one thing, that HMA filter is not mandatory to use because it is quite costly and not always available. So it's not necessary to use an HMA filter always. If it is available, we can use, otherwise we can work without the HMA filter. And our last step is to change this old track tie. So gently we will remove this old track tie and we'll replace it with a new track tie, and we'll take a new track tie for it. We'll ask the patient to just lift his neck. राकेश जी, आप थोड़ा सा अपनी गर्दन को ऊपर करेंगे? Yes. Thank you. You have to be very, very careful. Now, while tying the track tie, we should see that there should be a gap. When we have replaced the old track tie with the new one, we will just make sure that there should be a space that you can insert your one finger. Otherwise it will be too tight and it won't be comfortable for the patient. Now after the complete procedure, we will remove this drape. And we will ask the patient how is feeling. ठीक है राकेश जी, कैसा सही लग रहा है आपको? कोई पेन तो नहीं है? ठीक है, सही महसूस कर रहे हैं? Thank you so much. Now at the end of the procedure, we can document if there is any abnormality while the procedure and what was the results of the procedure. So documentation is very important at the end of the procedure.
Hello.
Yes,
Hello.
ma'am, we can hear you.
Okay, it is a very good video, Mamta and her team. Communicating with the patient is very important. Yes, with this we could see in her this one demonstration, she was communicating very well with the patient while doing a procedure. So I really appreciate the entire team for the preparation. And a few points to add on, like when we are doing tracheostomy care, which includes, first one is the changing the inner tube, second one is the suctioning. So in the hospital, there is no problem that we can use the suction which is available in the hospital. But at home care, there are facilities available, like hand operated suctions are there. And if the patients are not affordable, that they can get a mucus sucker, like which we earlier days we used to use during delivery to suck the mucus of the baby. So that can be suggested, given suggestion to the patients. And cleaning tube site, like the points which we have to keep is, first one is the changing the inner tube, second one is the suctioning, third one is cleaning the site, the fourth one is the changing the dressing around the stoma. That is, these are the four aspects we have to concentrate. Regarding the tubes, we have three types of tubes. The first one is the just cuffed one, second one is the uncuffed one, the third one is the metal one. The cuffed tube also has two types. The cuffed tube with the reusable inner cannula is there. Cuffed tube with the disposable inner cannula is also there. The cuffless tubes, it was explained in the video. It can be used for a patient's non-ventilated patients who have no difficulty in swallowing or no danger in aspiration. They can be used. And because there is no cuff in that, it allows the air to pass on and patients can cough or speak. And this also has got two types. That is the cuffless tube, reusable inner cannula, and cuffless tube with the disposable inner cannula. There are two types are there, and one more type is also there. That is a fenestrated cuffed one, which has an opening in the back of the cannula, which like if the tube is blocked up, no, that patient can that it allows the air to pass on the back of the trachea and the larynx, so that they can breathe normally and speak, cough through this. And tracheostomy tube, while the patients are on tracheostomy tube, we need to train them for different mode of communication, or closing the tube and talking to the like trying to communicate with others. And while the patients are on tracheostomy, we need to teach the caregivers to assess the mental status. Like some patients may be confused or lethargy or maybe restlessness. This shows that they are not that maybe tube may be blocked. So that we have to teach to the caregivers. And suctioning, like before they take out the inner tube, they have to do the suctioning. If secretions are there, then they have to take out. And they need to observe for reflexes like a gag and swallowing reflexes, and they need to assess the stoma for some patients will come with the fistula, or if it is left open, like even the maggots we have seen around the tracheostomy site. So that we have to educate to the relatives. Never they should leave that open, like they should put some gauze around it so that the flies will not sit over it. And we also need to assess for a subcutaneous emphysema, like crepes around the tube, like if there is an air leakage that can affect the patients further, so that we should teach to them. And while doing a procedure, we need to allow the patient to we should make the patient to lie on a Fowler's position. That is very important. And the next one is if secretions are more, the caregiver should wear a mask, because when the tube is open, if they cough out, the secretions can fall on the caregiver's face. So that we have to keep it in mind. And while taking out the inner tube, in case of metal, we need to unlock it and then we have to pull it out. And while cleaning the stoma site, we have to clean it from inner to outer. And that is very important. And we can put the Vaseline gauze, sterile Vaseline gauze around also, so that it prevents the excoriation. And if the patients are in need of oxygenation, before we do the suctioning, we need to do the, we have to give a pre-oxygenation if the patients are on oxygenation. And suctioning should be given only for 10 seconds. And we need to watch the heart rate. If it is more tachycardia or bradycardia, we should not do the suctioning. And tie, when we are changing the tie, the tie, like we need to hold both the side of the tube, because dislodgement can happen. Then only we have to change both the side, we have to hold it tightly, then only we have to remove the tie, otherwise it can endanger the patient. And then what else? Then while like some patients, they are on tracheostomy, like if they are conscious, alert, and they can also do the tracheostomy by looking at the mirror. That will empower our patient. So that can be taught to the patient, like they can do the self cleaning. And this metal tube, like if you don't have a brush, like we can put a cloth inside out, like that we can clean it. And this has to be boiled for 15 minutes. Then we can take it out and then cool it, and then we have to replace it. And before replacing also, we have to do the suctioning, then we have to replace. And don't forget to put that lock. That is very important. And the tie can also be instead of in white color, if it is in black color, so we not change it frequently. And for a male patient, if they want to shave, then we have to put before shaving, they have to put the cloth over the tracheostomy, then they have to do the shaving. And you may having a doubt that if the tube comes out, what they are supposed to do. They have to go to the hospital as quickly as possible. So this is what I wanted to contribute. Thank you. Now the session is open for question and answer.
Anu, please come
on. So far, I couldn't see any questions in the chat box. So I really wish to hear more from Stella ma'am regarding the practical issues like one can have while handling these type of patients in a home care setting. We have covered four major topics now. So what are the practical issues and tips and tricks from your experience?
Thank you, Anu, so much. First of all, about the lymphedema. Lymphedema is one of the things which Shiny has shown the speaker. It's a simple lymphatic drainage, massage, which can be done by the patient and can be helped by the bystander also. Any family member can help. And if they follow it properly, it can be well managed, and within you can see the change of any edema within 1 week to 2 weeks. You can see that the edema is getting reduced, and within 1 month the patient can shift to this one stockings. So that is very important. At least for 3 days, just admit the patient in your hospital, teach them, let you demonstrate, and let the family member also demonstrate you, and then you can discharge the patient and make a follow-up in the home care. But very strictly, you have to tell the patient whenever they are using multi-layer bandaging, not to use in the night, stockings. Multi-layer bandaging is used for 24 hours. So early morning, if they want to take a bath, they can just remove, take a bath and reapply it. Only after the shape comes for the limb, they can go for a stockings. Because many times it happens, patients use stockings in the morning, daytime, and in the night time they shift to multi-layer bandaging. That should not be allowed. That is the main thing. The second thing in the lymphedema, we have to be very careful when you are assessing the patient, because there are a lot of contraindications that we should not to go for any management. Especially, you can ask just simple questions to the patients like, when you walk, do you feel breathless? Because at times you don't know whether the patient is having any cardiac problems, patient is having any mets to the lungs, we don't know. So again, simple questions if you ask, they may tell you, yeah, while walking, I get breathless, I start coughing. So these are some indications showing to you that there is some contraindication that we cannot start the lymphedema management. So immediately you can direct to the physician so that they can go for further investigation to find out, like one maybe some chest CT or something, to find out if the patient is having mets to the lungs or etc. Okay, so that is very important. So, and especially patients like diabetic patient, hypertensive patients, be careful before starting a lymphedema management. And especially many of the patients comes with cellulitis. So you all know what are the signs and symptoms of cellulitis. So accordingly, the patient has to be treated, and when the cellulitis is treated well, then they can go for a lymphedema management. This is very important, lymphedema management, and this has to be started as soon as the patient has undergone his surgery and discharged from the hospital. Please, before discharge, teach the patient, tell the patient anytime they feel there is a change in their arm, that is on the side where their surgery has undergone, immediately to come to the hospital, and of course to follow all the exercise that is being taught from the hospital. That is very important. Now the second one, wound, wound management, it was done very well. But something, little things to add is, in a practically at home, especially a patient, you think they are in the village or a poor patients, they won't be able to buy all these things that we have shown you. The maybe the bandages, even the dressing materials. Okay, so what they can use is clean, washed, dried cotton clothes. They can use cotton clothes, clean, dried it. They can steam at home itself. They can cut into the size of the wound. They can steam at home, and this can be used. After steaming it, they have to just keep all these materials in a washed, dry box with a lid. And this has to be sterilized every third day. That is very important. The second important thing is, as she said, hand washing should be taught to the patient and the family. The third thing is not to touch directly with their hand, with their fingers, the gauze pieces or the materials, dressing materials, what they have used. The best thing what they can use is they can use two steel spoons, the spatula of the spoon, they can just put it in the hot water, that they can use as a, what is it, like a thumb forceps or an artery forceps. They can use even, they can even use, nowadays we get wooden spoons, wooden forks. These also can be used as a spatula, as a artery forceps to just to remove the dressing materials from the box to the. And one other thing is, at home itself, they can use small tube steel bowls. They can keep separately for the patient's use. For one for normal saline, another one to mix, if they want to mix metrogel powder or something, they can use. And they should be kept separately for the only for the patient. Third thing, normal saline can be made at home, homemade saline. 2 teaspoons of salt in 1 liter of water and just boil it and keep it aside for the use of wound cleaning, for mouthwash, everything we can use this. These are the some things which I want to add, and of course dispose the whatever materials we have used, immediately it has to be burnt. Disposal is very, very important in a home settings. Next is the tracheostomy. Tracheostomy, I just want to add, already Lata has added a lot, many of the points. One point is, when a patient is not able to speak, better to tell them to write and keep it so that they won't forget whatever issues and problems they face day to day, they can just put it in writing. Second thing, wet gauze they have to cover. In the opening, they should always cover it a wet gauze. Wet must not, our ordinary water is enough water. Just wet it nicely, squeeze it, and just put it on the opening. That's the inner opening. Just cover it to prevent not only the insects and dust, also to moisten the air what we are inhaling. So these are the some of the But of course, steam inhalation can be, if there is a thick secretions, you can give them steam inhalation also so that the secretions will loosen and it comes out. But very simple, mild coughing exercise also important. But only thing is, while the patient is coughing, they have to hold with their 2 fingers the tracheostomy tube. Otherwise, it may get dislodged. Okay, thank you all so much. Thank you, Anu. Thank you, Sangeeta.
Thank you so much, ma'am. Actually, these kind of practical tips helps any nurses, especially during health education, because most of our patients wish to be at home, and we as nurses have to help them how to spend their days comfortably at home. So, inviting next speaker's video, a subcutaneous infusion by Sumitra.
So Sumitra is going from Mahavir Jain Hospital, will be talking about subcutaneous injections or infusion, which usually used in palliative care. Yes, over to you, Sumita.
Hello, I am Sumitra Chaudhary, working as an in charge of palliative care department at Bhagwan Mahavir Cancer Hospital, Jaipur. Generally, the management of multi-symptoms in terminally ill patients requires administration of medications through a safe, reliable and effective route. Though intravenous route is commonly used for the administration of medications and for hydration in patients with advanced illness, establishing an intravenous route can be challenging. Peripheral or central venous catheter are prone to complication and infections and does not allow for long-term care planning, particularly in outpatient setting. The clinical practice of subcutaneous administration of medications is flexible, broadly feasible and safe method in patients with advanced disease, and also it can be inserted or maintained by caretakers. The risk of infection is low. It is ideally when the drug volume given is low. Subcutaneous route can be also used to facilitate hydration in end of life phase. So let's discuss the indications for subcutaneous route of drug administration. The indications are: first one, dysphagia; second one, nausea, vomiting; third one, gastrointestinal intolerance; fourth one, altered mental status; fifth one, bowel obstruction; sixth one, oral pill burden; seventh one, intense breathlessness. As we already discussed that subcutaneous administration is a low-cost procedure with less technical skills and can be performed in any care settings. So now let's look at how to perform the procedure. First and foremost things we have to do: explain the procedure to patient. Secondly, we have to take consent about procedure and drug to be administered. Equipments we needed: first 24 and 26 number cannula, second gloves, tegadrum, betadine, spirit, dry cotton. Next, we need to choose an appropriate site for placing the cannula for subcutaneous injection. The sites that are easily accessed, such as the chest and abdomen, are more ideal. Let's do the procedure. First, wear the gloves. Next step, we clean the area with betadine and wait for 30 seconds, and the same area we clean with spirit and wait for 30 seconds. Next step, we insert the cannula at 45-degree angle to skin surface as shown in and fix the cannula with tegaderm. Started drug delivery slowly and check local site for any reaction, redness, swelling, tenderness, itching, etc. The subcutaneous catheter can be placed for 3 to 5 days if there are no signs of local skin irritation. In our hospital, we are using subcutaneous for antiemetic and opioids, but it can be used for other drugs shown in slides. Contraindication for subcutaneous administration are local skin problem, existing tissue edema, cite the recent radiation, edemates limbs, painful sites, induration area, overbony prominence. Subcutaneous administration of fluid is not appropriate when rapid volume replacement is required, such as in shock or significant dehydration. Few things to be kept in mind while administering subcutaneous injection. If medication are given via subcutaneous catheter, no more than 2 ml should be given at a time at the site. If more than 2 ml need to be administered, use multiple sites. If more than one medication is to be given, wait for 20 to 30 minutes before the administration of second medications. Thank you.
So thank you so much, Sumitra. Even not only the cannula, we can use also the scalp pen, butterfly, what we call butterfly needles also we can use for the subcutaneous drugs and for the infusion. But so one more thing is infusions also can be given when the patient is in dehydration, otherwise in end of life care, and people are insisting, especially families insisting you that they want the patient to be given something. Usually they say give little glucose, give little IV fluids. It can be, but we have to use only normal saline is used for subcutaneous infusion. That also 60 ml per hour. But over 24 hours we can give about 500 ml to 1000 ml we can give for a patient. But that also, if it is only needed, we have to. So most of the time when a patient is in end of life care, we need to communicate with the patient, family member about the condition of the patient and whether it is really needed or not. That is very important because most of the things we can manage through communication. So that we have to keep in mind. So we can go for the next speaker, next one. So the next topic is non-pharmacological management of breathlessness by Durga Bhavani.
Greetings from Homi Baba Cancer Hospital and Research Center, Visakhapatnam. Today, in this video, we would like to show nurse demonstration of the non-pharmacological management of symptoms. In this role play, we have a patient, Hema, 42 years old, who is being treated for lung cancer. She has reported for her review today. She is accompanied by her caregiver, who is her sister, Uma. The nurse in charge is Durga. Presenting Department of Palliative Medicine, Homi Baba Cancer Hospital and Research Center, Visakhapatnam.
Good morning. How are you feeling today?
Oh, she is very breathless most of the time. We give her all the medicines and now the doctor has also changed the dosage. We try to give her the laxatives, but she refuses to take it daily, as she says she is too breathless after she uses the toilet. We have given her a comfortable room also separately so that nobody disturbs her, but still she is unable to sleep.
Thank you, Uma. Don't worry. The dose change will definitely help you. Now I will explain you simple practices which will help you to decrease your feeling of breathlessness. The breathlessness you feel is due to the disease. The activity you perform and the fear and the anxiety will also increases the breathlessness. Anyone in your place would feel the same. Now let us start when you wake up. When you start your activities, do it slowly. And when you do bath, keep the chair in the bathroom, sit on it and enjoy your bath. Dress up very slowly. Please don't lock the bathroom door. This way, if you need any help, you will find it immediately. Rather than avoiding the laxative, you must actually take adequate laxative so that you are able to pass motion every day. This way, you don't have to strain. Because straining actually increases the breathlessness.
Thank you for explaining that to me. So I will pace my activities of the day very slowly.
And when you eat, take soft and mashed food of your choice because chewing itself is tiresome. It will also increases the breathlessness. So eat food in a very soft way of your choice.
Oh yes, I could do that. I'll try to give her soft mashed food.
Also try to get a handheld fan. The breeze from the fan would actually act like a oxygen. It will decreases the breathlessness.
Sure, I will get a handheld fan right away.
Now I will teach you a simple breathing technique which is called pursed lip breathing. You can watch me to do it. You can do it in a sitting or in lying position and you will be able to do it automatically when you practice it. I am going to demonstrate breathing control technique which is called pursed lip breathing. This technique can be done in sitting or in lying position. Now step 1. First, make your shoulders relaxed. Step 2. Inhale the air into the abdomen like you are smelling a flower. Pause for 2 seconds. 1, 2. Now exhale the air like you are blowing a candle. Exhalation should be 4 to 6 seconds. Now we will practice it together. Step 1. Please relax your shoulders. Step 2. Inhale the air like you are smelling a flower. Step 3. Blow the air like you are blowing a candle for 4 to 6 seconds. Like a whistle.
Thank you for explaining that to me.
You're
I'll definitely try this. Maybe it will help me, but often I get scared of this fact that there may be nobody around me when I'm breathless. And I often see myself losing sleep because of this thought. We could also take her around the house, but she insists on doing things on her own and she cannot perform it. And this is the reason why she'll be sitting in this one corner of the room all the time.
It's okay. Hema, please use wheelchair or walking aids for your help. They are your friends. They are helping you to enjoy your things you would like to do. If you go to your garden, wouldn't you enjoy the feeling? And because you have the disease in your bones, these aids will ensure that you don't have to fall. So please use them. They'll help you to breathe easier and you can spend that energy on what you want to do and like to do. Avoid slippery surfaces so that you can avoid falls. Would you please try that?
I will.
And when you do some activity in the day, you'll sleep better at the night. Keep a bell around, keep your door unlocked. Did you tell to the doctor about your disturbed sleep?
Yes, he did. He asked me if it was pain or thoughts. He also asked me to discuss with you about sleep hygiene. Could you tell me about it?
Oh yes, I'll explain that for you. Please have fixed sleep timings. Make sure that you don't eat too much or too less before going to sleep. Maintain a gap of 45 minutes between the dinner and bedtime. Try to avoid coffee and tea before bedtime. Please urinate before you sleep and ensure that your clothes are comfortable and your bed is clean. Check the lights and the temperature in the room. Exposure of light should be low. About 30 minutes before going to sleep, please switch off your TV and mobile. You could read books, the hard copy ones. Try to listen to the music you like. soft instrumental maybe, or an audiobook. Try to relax while lying on the bed. Keep your daytime sleep up to 45 minutes or 1 hour. While relaxing in the daytime, avoid spending wake-up time on bed. Sitting or doing different activities in the other room can be helpful. Would you try that? And have you noted that, Uma?
Yes, I have noted everything and we'll try to follow all of it. Won't we, Emma?
Yes, thank you so much for explaining all this. I will try and let you know.
Please do not hesitate to call us if you have any queries. Here are your contact details for your next follow-up.
Thank you.
Thank you. Thank you.
Hema was practicing these techniques at home and was on regular follow-up. Subsequently, weeks later, we had a visit from her sister Uma, who is very anxious. Let's see what happened.
Sister,
Please sit. Doctor has just called me. What's happening?
oh sister, Hima is very sick. She's talking differently. She's restless. She's not able to sleep at night. I don't know what is happening. We all are very, very worried. Doctor gave us some medications, but he also asked me to meet you once.
Yes, doctor just called me. Probably she is in delirium. She is very sick. I'll tell you few things, few do's and don'ts. Please keep her in her favorite place, in her familiar surroundings and in her familiar sounds. Please don't change anything. If she is talking irrelevantly, please don't confront her. Accept what she says. Keep calm. Keep oriented with the surroundings. Keep a newspaper, a clock, music, TV program of her choice if it is okay with her. Please keep the windows open so that she will know when it is day and when it is night. It will be reassuring her if the family is around her. Familiar people, don't get scared. The medications will also help her. Will you please try this?
Sure, sister. I'll do this. I'm a little relaxed now. Now I'll go home and I'll see what can be done. I'll give you a call if needed.
Please don't hesitate to call us. Thank you.
One main thing is whenever the patient exerts a lot, they feel breathless also. In such cases, if the patient wants to go to the toilet, just ask the patient to break their walk steps. Like just let them walk 2 steps, break it for some time, be standing, then again take 2 steps. So what happens, but one stretch when they go to the toilet, they are exerting too much. So break the steps so that they won't feel breathless. The next thing is, many of patients, they will feel breathless when there is a thick secretion. They are not able to cough it out also, and they try to cough it, but it's because of thick secretions, they won't be able to breathe properly. So that is done. So at home means, again, we can give just a simple steam inhalation, and of course teach the family member about the chest physio, how to do a chest physio, so that they can try at home. So these are the simple measures that we, and to give the patient, especially now northern sides of winter season and all, not to give any even room temperature cold fluids also. Just it should be lukewarm. Whatever fluids they take, it should be lukewarm so that they won't feel more cold. And so these things, and even taking lukewarm water, what happens that our cough is also get little bit soothing. Okay. And of course, if there is this one, what to say, cough with severe lot of excretions, secretions are there, then they have to go for some expectorations. But before that, best is steam inhalation. Steam inhalation always helps to bring out thick secretions out. These are some few points which I have to add. So we can go for the next one.
Ma'am, introduce the topic by Neelima ma'am.
Okay, so I think this is the last presentation for today's uh, nursing conference, and I would like to invite Mehuli for her oral care video. I invite Mehuli. Please share her video.
Good morning. I am Miheli Chakraborty from Ruma Abedana Hospice. I am a palliative care nurse, and today I am going to demonstrate the procedure of how to do an oral care for conscious independent patients and for unconscious bedridden patients. So, two are different. Now, I am going to show the articles: Macintosh, toothbrush, toothpaste and a tongue cleaner, a jar containing water, patient's glass, gloves, one pair of gloves and kidney tray, and a paper and pen for documenting the procedure. Good morning, Mrs. X. Today we have Mrs. X. We are going to do the oral care for you. It will help you to maintain a good oral hygiene, okay? If you have any problem, just let me know. This is a very clean procedure, so we need only gloves. I have already hand washed myself. And now I am going to give the Macintosh on her chest. So, this is a toothbrush and a toothpaste. Before every procedure, we need to assess the oral mucosa first, and then we choose how to, what agent we can use, and the patient can do by herself. As this patient can do by herself, we will just assist her for doing the brushing. We will teach the patient to have to brush her teeth by vertically and then anterior and then posterior, so that all the debris and plaques come out, and we will just assist her. In your mouth, okay? The patient mostly develop mucositis, stomatitis, xerostomia, candidiasis and halitosis. For different kind of oral problems, we used to mix the agents, or we used to select the agents for different problems. Now we will discard it, and then we will discard the gloves, and then we will do the waste management and then document it after the procedure. If any problem arises, we will document it and report it to the physician, so that it will help the patient and us. When we were assessing her oral mucosa, we have assessed that she has a clean oral mucosa and she has not a coated tongue. If she has a coated tongue, if the patient has a coated tongue, we use a tongue cleaner for that, so that patient can clean her tongue. But for her, we are not using it. If the patient is conscious but cannot use the toothbrush, then the articles are completely same, but we just use normal saline with lime, which gives a good refreshment, and normal saline give a good bactericidal effect for the oral mucosa, and we use emollient at last for a moist lips and moist oral mucosa. Other rest of the articles are completely same for them. We are considering her as she has oral problems and she cannot use the, for mucositis she cannot use the toothbrush and toothpaste. So, this procedure is completely same. We will give a chest towel into her, but for her we are using normal saline with lime. Normal saline gives a bactericidal effect and lime gives a good refreshment. So, we are giving her that. Assessing our oral mucosa is very important. So, this is the normal saline which we will use. We will tell the patient to just rinse her mouth with it, because we are considering her, she cannot use the toothbrush and toothpaste. After this, we will just give this water. After finishing it, we will just give the water so that she can wash it, rinse it with water only at last, at least twice. That's it. So at last we will just give we'll just moist her lips and the tongue. Yes. This is the tray for the oral care for the unconscious patients. So the big tray containing a chest towel and Macintosh, a small tray containing artery forceps, dissecting forceps and tongue depressor. You can also use mouth gag for opening the mouth of an unconscious patient. Then gloves, normal saline, and a jar of containing water, emollient, and then a small tray. We have taken a sectional tray for the gauze pieces, and so that we can pour the normal saline and water in sectional tray. And at last kidney dish for discarding the materials, and paper and pen for documentation. She, Mrs. X, is an unconscious patient, and I have given the left lateral position for preventing the choking. We used to demonstrate the family members also, so that they can take care of the oral hygiene too hourly. It is very, very important for them. And I have hand washed my hands. So this is the tray. I am taking the Macintosh. And I am just placing it here. This is the chest towel. I am just placing it here. Again, this is a basic procedure, so it does not need any sterile gloves. This is just normal unsterile gloves. And I am placing the kidney tray here. And we will use normal saline. We will just dip it here and water in here. We are using sectional tray. You can also use different gallipots for different things. I have taken the artery forceps. Before every oral procedure, please make sure that you do a proper oral assessment. And so this is the artery forceps I am using, and this is a gauze piece. So I am just placing it like this and just turn two sides and the upper part like this. Just clip it so that it does not slip. Okay. Now I am going to dip it in the normal saline. You can squeeze it with a dissecting forceps, and then you can just clean the patient's mouth. You can just clean the patient's mouth. Just discard it. So this is the way I am going to, I am cleaning her. After every clean, discard the gauze in the waste boxes. Please make sure that it is not slipping. Then clean the teeth and tongue. If the patient is opening the tongue, that is fine. Taking the normal saline and giving in her mouth. After every clean, please try to discard one gauze. Now, if the patient cannot open her tongue, if you cannot open it, we can use this tongue depressor, and then which is wrapped by gauze, and then try to open her mouth with this. Don't put your finger inside and then just open it and clean it. You can dip it inside normal saline, or you just open it first and then take this normal saline and open, and the tongue will be cleaned. Okay. So, after every clean, at last you can use the water. This is the water. Clean the whole mouth with it and discard it. After this, use the emollient on the lips, on the tongue, inside the mouth, so that it will give a moisture maintaining inside the mouth. Then discard all this in the different waste boxes as per CDC guideline, and then I will discard my gloves and report it into the reporting file. The first thing in palliative care, we teach the family members to take care of their patients. So, most of the time we teach them how to do it and what is the importance for every aspect, every aspect. So, that is very important. You can use chlorhexidine, normal saline, normal water, or if halitosis presents, we do a metronidazole wash, but that is very bittering test, but it has a bactericidal effect. Both all of them are very nice. And for stomatitis, xerostomia, you just tell the patient to have ice chips in it, so that it secretes more saliva from them. They can use pineapple chips, so that will enhance the salivary secretions. If the patient has candidiasis, then they can have oral antifungal drugs and candidiasis and cotrimoxazole mouth paint. But mouth care is very, very important. For mucositis also, that is very, very important. Normal saline does an excellent work for all of our patients. Thank you so much. Hope this video helps you, and this all the oral care things we do, that really helps our patients and the families to take care by themselves or by the family members. Thank you so much.
Thank you, Meheli. That was nice efforts by Meheli to show the oral care. But that was a very splendid video. But when we talk about palliative care, most of our patients, when they are at home, maybe at home settings, they cannot use artery forceps or thumb forceps for taking care of their mouth. And patients' relatives have many queries for their oral care. Some patients, when they are on rice tube feed, then we send them with the rice tube feed. Some patients and their family members, even they think that when the patient is not taking orally, oral care is not that much important. So we need to teach them that why oral care is important, why oral mucosa is so important to making them nice, clean, and feeling better, and like living like a normal being. So that is why oral care is very important for nursing aspects. And when the patient, as Sister Stella has already mentioned this, normal saline patient can make at home, and it is the best thing that they can use. Otherwise, with lukewarm water also, they can rinse their mouth. If patient is conscious, they can rinse their mouth after eating anything else, anything, or after, even before and after giving rice to feed also. If patient is unconscious, that time the relatives has to be taught very carefully how to open the patient's mouth when the patient is bedridden or he is not able or unconscious. because when if relative try to open the mouth forcefully, putting their fingers in the mouth of the patient can they can have a bite on their finger, or if patient is having any artificial tooth, or patient is having any tooth which is moving and about to get off, it can choke the patient also. So these all things has to be taught very carefully to the patient and their relatives while taking care of their oral. And yes, there are many things available in market also, like when the patients are in hospital, we suggest, if they have mucositis, we suggest BG pen, triple gargles, many things. Even we suggest them magic mouthwash. So these things are very useful for the patients, and palliative care patients require this education. And I thank each and everyone for sharing their videos. And that's it from my side. Uh, Anything else?
I request Terry to add any points which we have not discussed so far. Anything from your side?
Yes, I think all the eminent faculty has covered most of the things. Just to reiterate a few, positioning is of paramount importance when we give oral care in an unconscious patient. Not even Fowler's position is recommended, because when the patient is in Fowler's position, and the moment we touch the mouth, the salivary secretions are accumulated, and these secretions seeps back to the throat, and if the patient cannot swallow effectively, it will directly go into the lungs. So in unconscious patient, oral care is always in lateral position, and no compromise in that. And one just to stress the importance of oral care, there are articles, research papers that suggest that in patients who are ventilated, daily brushing twice daily in ICUs greatly brings down the incidence of ventilator associated pneumonia. It is a very simple procedure, but can make a difference of life and death in a ventilated patients. And other thing, for a patient with a malignant ulcers in the mouth, a good oral care can really improve the sense of well-being. A clean oral cavity and a good breath really improves the sense of well-being. So these are all the things that I would like to reiterate. Thank you.
Yeah, Terry, your point is well noted. That's very right what you said, because I have been working in ICU with ventilators. We used to give in all the shifts, we used to give oral care for the patient. It's very simple as you said. So, and nurses has to carry out this one. So, Sangeeta?
We come to an end. I would like to call Anu to say thanks.
It's an honor for me to be here. First of all, like I thank each and every moderators, chairperson, the speakers for doing such a great amount of hard work in such a small time, and to make this session like very good, great success. Thank you all, and see you in next year.
And we have finished on time.
Yes.
Thank you.
Thank you to the team, and for the participants, we would like to say we will take your suggestions to Anju ma'am, and we'll try to circulate all the videos. It will be useful in each organization to teach and train the nurses. Thank you so much.
Thank you so much. Have a great day.
Thank you all.